Hello and welcome to Pulse Check with Archer Nursing, where nursing comes to life. In this podcast, you give us 15 minutes of your day, and we'll take one complicated nursing topic and make it easy. Ready for nursing to be fun? I'm Morgan, and today we're tackling meningitis. As always, let's kick it off with our practice question. A nurse in the emergency department is assessing a 19-year-old college student who reports a sudden onset severe headache. They are also febrile and report a stiff neck. On assessment, they are squinting and turning away from the overhead light, saying that the light makes the pain worse. Which of the following is the nurse's priority action? We have A, placing the client on droplet precautions. B, obtaining 2 sets of blood cultures and then initiating IV broad-spectrum antibiotics. C, scheduling a lumbar puncture. Or D, administering acetaminophen as prescribed. Think about your answer and we'll come back at the end of the episode. But first, let's deep dive into the A and B behind meningitis. We have to think about our brain and how it works. The brain and the spinal cord, first and foremost, are wrapped in protective layers called meninges. Think of them kind of like a 3-layer hoodie, more or less, around the nervous system. Outer layer is the dura. Then in the middle, we have the arachnoid, and the pia is that delicate inner layer that's just hugging the brain and spinal cord itself. Between the arachnoid and the pia, those bottom 2 layers, is the subarachnoid space. So below the arachnoid, subarachnoid, it's between those 2 layers. And it's filled with CSF. That's our cerebrospinal fluid. This is kind of like the brain's personal pool of water. It just kind of cushions everything, makes it nice and cushy. And it also carries nutrients, removes waste, and keeps the environment stable so neurons can do their job without getting jostled around every time, you move. So what happens in meningitis? It's when we get inflammation on one of those meninges. The meninges are the 3 layers, remember? If one of them gets inflamed, we've got meningitis. This is especially common in that subarachnoid space where the CSF we just talked about lives. When inflammation shows up here, I want you to remember the brain is a closed container, all right? It can't get bigger, expand. It's in this hard box of the skull. So when it gets inflamed, it gets a little irritated. There is just only so much room for that inflammation. Remember that when we have inflammation, we are getting immune cells, extra fluid, inflammatory chemicals. There is more stuff. That swelling is taking up room in a place where we do not have extra room. This is obviously a problem, okay? It's why meningitis increases intracranial pressure, which is a huge problem. We get more stuff in this rigid box of the skull, we have more pressure. And when you have pressure in the brain, it pushes on our blood vessels, which decreases how much blood can be carried to the brain. We call that decreased cerebral perfusion. And with less blood going to the brain, decreased cerebral perfusion, we can have seizures. We could even, worst case scenario, have a herniation if we don't catch and treat meningitis quickly. So backing it up, how did this infection get there in the first place? Why are we having this inflammation in our meninges? Well, bacteria and viruses usually reach the meninges by traveling through the bloodstream and then crossing the blood-brain barrier. The blood-brain barrier is kind of like that VIP security level at somewhere exclusive. Usually, it's going to keep all the bad guys out, the toxins, the pathogens, whatnot. But certain organisms are good at breaking in, especially if the immune system is stressed. So if we have an ear or a sinus infection nearby, maybe it was somebody who's unvaccinated, then that pathogen can kind of sneak on in, get into the CSF. We get that inflammation. We get more stuff going, more pressure, higher ICP, lower cerebral perfusion pressure, and it spirals from there. It spirals really fast because up here, once we have passed the blood-brain barrier, we're up in the CSF, we don't have the same immune defenses as we do in our blood. So that chaos, it spreads really fast. And that's why bacterial versus viral is going to matter a lot. Okay, so I'm going to start off with viral. because viral meningitis tends to be more common and less severe. The immune response is less explosive, and many cases can resolve with supportive care. Bacterial meningitis, though, I'm cringing just saying it, is one of those that just do not pass go. We do not want to deal with bacterial meningitis. Bacteria in the CSF, you guys, they trigger a massive inflammatory response. Our neutrophils are those white blood cells that eat up bacteria. They are going to rush in. They are going to bring their proteins, their debris. They're going to really try to eat everything up. And those meninges are going to get real irritated. Okay. We're bringing in extra fluid. We're getting more pressure going on. These irritated meninges are like sandpaper rubbing against nerves, and that irritation causes all our symptoms. It's why the patient's neck gets really stiff, why light hurts. It's not drama. It's that those meninges are inflamed, pushing on nerves and sending pain signals. The increasing pressure is blocking normal CSF flow. That CSF can't circulate, so it's backing up. Pressure's going up, and the brain is getting squeezed. That is going to cause the severe pounding headache that most clients report. It can also cause vomiting, altered mental status, and seizures. Obviously, big red flags. So let's put those red flags into a little case study here and walk through what can happen in meningitis. You are going to be an ED nurse today. You're walking into a really chaotic shift. The waiting room looks like a line to get into a concert. And as you clock in, EMS is rolling in with, let's say, an 18-year-old that is coming in from the local university. Their chief complaint is fever and confusion. When your assessment, you see that they're sweating, they've got their eyes squeezed shut, they got their hand pressed over to their forehead, like, oh my gosh, they think it's going to split open. And when they look up at you, they're squinting and turning away from the lights. So I'm already a little suspicious here with the light squinting. They're pale or diaphoretic. They clearly have a headache. Something's going on. The first assessment I am going to do is I am going to try and kind of evaluate those meninges through something called Kernig and Brudinsky's sign. I basically want to see how stiff, how inflamed are those meninges. Quick way to do this, have them bring their chin to their chest. And if they're not able to do that and their knee jerks up, that's telling us those meninges are real inflamed. So red flags going up right away. Now, for this client, I'm going to give you a little bonus assessment finding here. As you undress them, you're getting into the gown, you notice tiny purple red spots on the torso. You press on it and they don't blanch. What is that? That's a petechial rash. And if you see that with photophobia, stiff neck, headache, you should be thinking meningitis. We are scared. And what you do first here as the nurse is going to matter. First, you need to protect everyone in that room because this can spread through respiratory droplets. So you got to put on a surgical mask. Put on a surgical mask on that client. Your droplet precautions need to be initiated immediately. If you are suspecting meningococcal meningitis, your priority is droplet precautions. Then you can continue your assessment. You can get your whole history. You can go find your thermometer with the covers that, is in another room. But right now, step one, protect everyone from turning this into a unit-wide exposure event by initiating droplet precautions. That is your priority. Okay, so you've done that. You've put your droplet precautions in place. Great. We don't know for sure yet that this is a bacterial meningitis. How are we diagnosing that? Gold standard is a lumbar puncture. We're going to actually get some of that CSF and look in there to see what we are dealing with. But honestly, the reality is that if bacterial meningitis is on the table, rapidly starting antibiotics, getting cultures, not delaying treatment while, you're doing paperwork and stuff is going to be very important. So by all means, we want to get an LP to confirm this, but The first thing you're probably going to be doing is getting blood cultures and then starting IV broad spectrum antibiotics, okay? In adults, oftentimes this is a cyclosporin plus vancomycin. Sometimes ampicillin is used depending on the age and whatnot. I almost always see vancomycin used. We want broad spectrum, hit it with the big guns. We are not taking chances. So those are your immediate priorities. 1, droplet precautions. 2, get your cultures. 3, start your antibiotics. And then we're getting that LP as all of this is unfolding. What are you monitoring for in the meantime? We are worried about bacterial meningitis. We're keeping an eye on their neurostatus. They can go from, confused to seizing really, really fast. You want to be looking at all those signs of increased ICP, intracranial pressure. If they become more lethargic, if they develop unequal pupils or posturing, they drop in level of consciousness, that is an emergency. You keep their head of the bed elevated so that we help reduce that pressure. You minimize stimulation, dim the lights, turn the TV off, keep it calm and quiet. And you also want to do your emergency checks. You got to have airway support ready in case their mental status deteriorates. Seizure precautions, pad those side rails, have suction ready, have oxygen ready. You are thinking ahead. Lastly, fever control. High temperature increases metabolic demand. So that antipyretic, usually acetaminophen, is really, really important. And now that you know that, it brings us back around to our practice question. Let's see if you can now get to the right answer and understand why. A nurse in the emergency department is assessing a 19-year-old college student who reports a sudden onset severe headache. They are also febrile and report a stiff neck. On assessment, they are squinting and turning away from the overhead light, saying that the light makes the pain worse. Which of the following is the nurse's priority action? We have A, placing the client on droplet precautions. B, obtaining 2 sets of blood cultures and then initiating IV broad spectrum antibiotics. C, scheduling a lumbar puncture. Or D, administering acetaminophen as prescribed. So which one is your priority action? Now, you're gonna do all these things. You're probably saying, Morgan, we talked about every single one of these in our case study in our episode. And you're right. But the question says, what is your priority? And the correct answer is A. This is a very suspicious case for bacterial meningitis. So we need them on droplet precautions ASAP. The priority is immediate isolation so that we prevent the spread while the medical workup and the treatment ramp up. That's the key takeaway for today. I really need you to make sure you know the signs and symptoms of a potential case of bacterial meningitis, the photophobia, the fever, the stiff necks, Bernig's and Kredinsky's sign, petechial rash. Any of those things should scream bacterial meningitis, and you should initiate droplet precautions right away. All right, future nurses, that is a wrap. If you found this pod helpful, I'd love to continue supporting your nursing journey through nursing school, the NCLEX, continuing ed, and beyond. Archer Nursing has you covered with on-demand video lectures, high-yield question banks, live case study reviews, and so much more. We want to help you master tough concepts and make it fun. So join us over at archerreview.com. Follow us on socials at Archer Nursing for more free nursing tips and study resources. Thanks for tuning in to Pulse Check with Archer Nursing. I'm Dr. Morgan Taylor, and I'll see you back next time.